And there was emerging this very effective repurposed drugs, initially hydroxychloroquine and then ivermectin. And I'm not going to be drawn into arguments because it's all over. We know they're very effective.
Yeah,
and
the debate's over.
The debate's over.
Yeah, we know they're both highly effective.
Lingers in the mind of those where it's of some value.
If given early, we know they're highly effective.
Absolutely, you must treat like any viral disease in the first 48 hours. But so this came out, and this became translated by October of 2020, before the vaccines, that into what's known as the Great Barrington Declaration, and that was signed by over 1 million scientists and doctors around the world. And basically, that set up a system whereby you must protect the vulnerable, which none of us did very well. But outside of that, let life more or less go on sensibly. Use sensible measures. So don't close down the schools. Don't stop people working. And if you look at the economic parameters of, say, Australia and Sweden, or Sweden and the rest of Europe, the basically impact economically was much greater on those other countries that didn't use the Swedish system. So again, I think what it does, it reinforces the value and importance of public health issues as the baseline for managing a pandemic.
Yeah. I mean, the only way I can explain this is in psychiatry there's a condition called folie à deux, and it's like an international folie à deux. You know, we were stupid enough to maybe lead the way, and then the Americans were stupid enough to follow. Well, parts of America were stupid enough to follow us, and Australia and New Zealand, Canada.
Well, we were the worst, yeah.
In terms of lockdown, I mean. And it was kind of self-replicating. Oh, Australia's had more lockdowns. We must have more lockdowns. And it was almost like a competition.
Well, we won.
But there was this complete abdication of application of existing known public health knowledge.
You know, your folie à deux is a very interesting. I have never thought of that, John.
It's the only way I can explain it.
Well, folie à deux is essentially cognitive dissonance.
Yeah.
Amongst two people.
Yeah.
And there is basic physiological linkage. What is well known, and I've certainly seen this many times in my own patients, that if you have a close couple and one dies from, say, I remember one particularly, from cancer, the other person has a highly significant chance, much greater chance of dying quickly than if their spouse had not died. So there is a physiological basis, but of course what happened in the world was that the selling of this great narrative was so good, so effective, so supported by figures that we had learnt to respect, that people, they still believe it. I had a very good friend who was in my group in medicine when we trained, ring me last night. To say that one of he's a very good, experienced general practitioner, and he said that one of his patients contacted him yesterday to say could he come and have his seventh vaccine. And I'd run into John at a medical meeting the other night, and we were chatting about various things. And he said, I didn't realise you had an interest in COVID. He said, I just wanted to pass this because I'm ready. I'm ready for my 7th vaccine. And so I had a little chat with him, and he said he had no idea that drugs like ivermectin actually had evidence that they worked.
And this is a doctor.
No idea that the vaccines, it's foolish to be having a 7th vaccine. Basically foolish to have a 7th vaccine in this day and age when we know it's going to drive negative immunity and give you more infections, probably. So here's a guy who's as good a general practitioner as you could find.
I mean, to me, that's terrifying, not just because he suffers from potential curiosity deficit disorder, because he's not reading primary source papers. But what terrifies me more is that the narrative that he is consuming is given as the only narrative.
True.
That he's been dictated to. So government, I used to do this with students. I'd say, right, get your pens out and write this down. And you know what? They all did.
And they believed it.
Yeah, yeah.
There was a time when people earned their position as being, there was this drip down effect of education, and you had respect for the person who was dripping down this education because they earned it.
But that's what the government's basically said. Right, all you doctors, get your notepads out. Write this down. I'm going to dictate. And
by the way, if you don't, there's punitive. We've still got doctors who can't work because they prescribed ivermectin when it was legal to do so.
Yeah.
Unbelievable.
It is quite incredible. I mean, I want to talk to you about something else of it, but just to conclude this this part of the talk, I just want to. I was grabbed by the last line of your paper, which will be out shortly, and we can publish a little bit of. The problem is not the science. It is the ethical issue facing individuals and institutes with much to lose. The science is clear to you and me, at least.
That's not a comment that I was directing to family practitioners, because I think just to make clear, because I think the family practitioners have been caught up in a destructive process of how they function and how they relate to their patients. That comment is a very real one in my view. That was directed at what is happening in my country and perhaps in yours, where big companies, Moderna in our country, has bought the politics and bought the institutes and the education institutes. It's poured multi-millions, billions of dollars into producing factories. One factory opened at Monash University in Victoria. This is a lovely story. Can I tell it?
Please, absolutely.
They opened the factory a few weeks ago, and the factory was opened and claimed and boasted, we can produce 100 million doses of vaccine. Now, what on earth are they going to produce those 100 million doses of vaccine for? It's sure not going to be just COVID. And so
about 4.5 for every person in Australia. Maybe you should start vaccinating the sheep, Robert.
Their aim is to replace highly efficient, highly effective vaccines for kids that save lives and don't hurt people with a messenger RNA vaccine which has question marks in red all over it. You can't see the issue for the question marks. And wait for this. It was opened by a politician, the Premier of Victoria.
Really, right?
And she got up and she said, now the next thing we're going to do, we're going to make a vaccine for the kids so they don't get respiratory RSV, syncytial virus disease.
RSV,
We all know this is a nasty infection in infants and kids. It underpins a lot of asthma and allergic issues. But there is a history. There is a history to this. It goes back to the 60s and 70s. And I was obviously only in kindergarten in those days, but I can remember that no one would touch a vaccine against RSV because if you got an aberrant immune response, when you got RSV, you weren't protected. You ended up in hospital and you could die from vaccine-promoted disease.
Yep.
So no one touched it. But if you notice how the companies have done this, they started saying, all you old people, we're going to make an RSV messenger RNA vaccine for you. Now, I've been around a long time, John. I can't remember, I'll be criticised for this, for missing these cases, but I can't remember treating an old person with RSV infection that I was terribly concerned about. I mean, of course, everyone gets RSV.
I can't remember that either. I've been in and out of clinical practice for 45 years, and I can't remember it. Not only that.
Look at the strategy. The strategy was to introduce it to old people, because we don't really count, and then move it into the kids where there's big money. Now, so they did a study in using this messenger RNA, and it was just basically at the same time as the Premier of Victoria saying, and what she said was that we're going to make this, every mother every mother is going to really appreciate this wonder RSV infection. 2 or 3 days after that, out came a little tiny statement hidden in small print. Oh, we put the RSV vaccine, messenger RNA vaccine study in infants, pause. We're pausing it because, dear me, 12.5%. That's basically 1 in 8 of the kids who were vaccinated ended up in hospital with life-threatening RSV infections, exactly as you'd predict. And the thing about messenger RNA vaccines is they're most likely to do this because these, quite frankly, I don't know if they're idiots or stupid or just very greedy people who run these companies. They didn't quite appreciate that when you inject a messenger RNA vaccine, you're not injecting the antigen to stimulate immunity. You're instructing a message to tell every cell in the body, because that's where the vaccine goes, to potentially make this antigen. So you have no control of the dose. You have no control of the pattern of immune response to that dose of antigen. And so if you really wanted to design a vaccine to cause death and destruction in young kids from RSV infection, you design a messenger RNA vaccine to do it.
There's 2 points.
Within days of this. So I wrote. I think I wrote in that article. I was a bit cheeky. I said it's interesting that within 2 days or so of the statement that should have been made was that every mother will know about RSV infection because it's going to potentially cause so many problems in their kids.
Absolutely. I mean, two real points there. I mean, the risks of mRNA, full stop. You've got toxicity from the lipid nanoparticles themselves. You've got the guaranteed systemic distribution of these tiny lipid nanoparticles. You've got transfection of cells in all parts of the body, potentially, all parts of the body, including the brain, the myocardium, the kidneys, the ovaries, the testes, or potential targets. The RNA could be taken in by those cells. Those cells will be obliged to produce this foreign protein. That will be expressed onto the surface of the cells. That will be recognized by the immune system, and the immune system can go around destroying cells potentially in the brain, the myocardium, the kidneys, the liver, the testes, the ovaries, everywhere. You've got that fundamental problem with mRNA. But the other one, just help me out, Robert, is the phenomena you talked about there, is it antibody-enhanced infection? Is that what it is? Yeah,
that's, well, immune enhanced, whether it's involved cells or molecules like antibodies, you can argue. But the concept is that if you immunise or inject an antigen from RSV and you get a particular pattern of response, those antibodies can actually facilitate disease when the virus is inhaled. And so we call that immune-enhanced infection.
Right.
Immunity is doing the wrong thing. This is very well recognised, and it's best recognised with RSV. And the nonsensical, the stupidity of trying to create a messenger RNA vaccine for RSV in infants.
Where immune enhancement is I mean, how long have you known about this immune enhancement?
I've known about it since 1960 when I was in kindergarten. I mean,
I'm glad I'm not in a tall building. I'd be threatened to take my life at this point.
They kept very quiet about it. People will be hearing about this for the first time. I had an email last night from one of my really good friends in Sydney, who is probably the most informed person of problems with messenger RNA vaccines. And I'd actually been talking to him by email about this particular issue. And he said, he hadn't seen that. And he hadn't seen it because it's been very carefully handled.
Control of information.
Control.
Absolutely. Good. So the other thing I was just going to mention before we go on to research was the RSV in the elderly, in the over 65s. You can't remember seeing it. I can't remember seeing it. And since this issue arose, I've taken issue to address several leading and ordinary, what you might call rank and file emergency physicians around the world. And strangely, none of them have seen it either.
Well, I think the thing is, John, we see it, but it's like a cough and a cold, you know.
You never get them into A&E or...
No, now, of course, with the technology, in fact, it's not just the doctor. I had one of my friends who lives in the same unit that I live here say that she came into my office where we are now saying she's got influenza A, but she felt too sick to go to the GP. I become the building GP a bit. And she said, I said, how do you know? Oh, she said, they've modified these yes-no tests from, you know, the COVID ones, where you now can pick up influenza A, influenza B, RSV, of course, and COVID. So the technology for rapid yes-no tests has changed, which I'm very interested, because I actually developed the first yes-no test. We did it for Helicobacter. It was the first yes-no test where patients or an individual can take just a drop of blood and within 2 minutes know, 3 or 4 minutes know that they've got Helicobacter, which in those days was, of course, the huge threat to humanity, causing peptic ulcers.
I mean, young people watching might not realise just how important what you've just said is. I mean, when I first started on a surgical ward, vagotomy and pyloroplasty was every other patient. You know, we used to cut these poor patients over, slice through the pyloric sphincter, cut the vagus nerves, and these patients suffered appallingly all their lives with peptic ulceration. And they used to perforate where the contents of their stomach or duodenum would pour out into their peritoneal sac, and they'd come in with bored abdomens in absolute agony.
Well, they'd bleed.
Terrible.
Yep.
All caused by Helicobacter.
When I was a resident doctor in Sydney, when we were on call at night, we knew that we were going to be seeing someone coming in with a life-threatening hemorrhage from their stomach because of bleeding ulcers. And you mentioned highly selective vagotomies and all these wonderful operations. I don't think the modern young trainee would probably know what some of these things are.
Hopefully not.
I do. I do have a clinic which is a mixed mainly immunology, of course, but I see a lot of people with gastroenterological diseases, and I haven't seen a peptic ulcer for 18 months to 2 years.
Fantastic.
10, 15, 20 years ago, over half the patients you'd see would be peptic ulcer disease.
Yeah. And of course, the bacteria, the Helicobacter, was actually originally discovered by our mutual friend Tom Brodie.
Well, no, Tom didn't discover it. It was discovered by two of my colleagues in Perth. What they did, it's an interesting. Are we having a
Yeah, go on. I can't resist it. Give us a quick one. Yeah.
Right. No, sadly, one of the two just died recently, but the pathologist of the two suddenly noticed that he was getting biopsies from stomachs because flexible endoscopy had just been discovered. In other words, putting a little tube down and having a look at the ulcer. And while they were there, they could just pinch a little bit. And he was being sent those little pinch bits of biopsies and seeing these funny spiral things. And there was an amazingly enthusiastic, a great guy, who was a young trainee registrar.
This is Barry Marshall,
And Barry was looking for a research project. Barry had no training in science, and he'd be the first to admit it. So he rocked into the pathologist, Warren, who had just been seeing these squiggly things. He said, I want a research project. And so he said, well, why don't you try to grow some of these bugs that I'm seeing? So Barry, of course, went up to the microbiology lab and said, look, I just want a few plates that I can grow things. And so he was doing all these endoscopies, taking biopsies and putting them on the plates. And of course, it didn't grow. And being a very untrained, sloppy scientist, he basically left these things while he went off to the eastern states where we have skiing to go skiing for a long weekend. And when he came back, they're still sitting on his on his desk, and there are all these little dots where they had grown, and that was changed history. And from there, of course, they identified, and again with the help of a number of other scientists in Sydney, and Tom Barodi. What Barry couldn't do was come up with an effective treatment. So if you really wanted to prove that the Helicobacter organism caused the ulcer, you had to get rid of it completely and prove that the ulcer went away and stayed away. Because at the time we had what's called H2 blockers, which prevented acid being produced.
Cimetidine, ranitidine.
Yeah. And so if you prevent acid being produced, the ulcer would heal. But of course, as soon as you stopped the drug, the ulcer would come back. And so you needed to be able to show that by getting rid of that bug, you got rid of the ulcer. And what Tom Barodi did was develop the triple therapy, which became the basis of treatment. And he was the first to prove that it wasn't... The guys in Perth got the Nobel Prize, rightly so. Yeah. My view has always been that Tom should have shared that. But they couldn't prove that they caused ulcers because they couldn't get rid effectively of the organism. Tom treated duodenal ulcer patients and 12 months later went back and looked at them and found all but about one of them had never recurred. Their ulcer never recurred. And so he proved that by getting rid of the infection, you got rid of the ulcer. And that was the huge breakthrough.
Fascinating. Of course, Barry famously drank a shot of it and
you
got a rather bad case of gastritis.
But you know, the funny thing is there's great competition between Australia and New Zealand, and mainly focused on rugby, and they always beat us, unfortunately. But a New Zealand gastroenterologist said, well, if an Australian can do this, so can I. But the problem was that Barry was lucky. He could get rid of it with simple antibiotics, whereas the poor guy in New Zealand couldn't, and had terrible bad breath for years as a result of not being able to get rid of his Helicobacter.
Well, I'm sure he needed Tom's eradication triple therapy.
Well, yeah, absolutely. I'm sure he ended up...
We'll probably do the trick,